Systemic ocular gonorrhea. The various lesions that may occur in the eyes as a result of systemic gonorrhea are enumerated as follows by Byers. Footnote: Gonorrheal ocular metastases, Montreal, 1908. The statistics throughout are from this monograph. In each case, the name of the discoverer and the date of discovery are placed in parentheses. Iritis, McKenzie. Conjunctivitis, Fournier, 1866. Iridochoroiditis, Kinninger, 1872. Keratitis, Colesman, 1882. Panophthalmitis, Martin, 1882. Optic neuritis, Panis, 1890. Dacroadenitis, Panis, 1894. Retinitis, Burkhardt, 1894. Tinnivitis, Puke, 1895. Thrombosis of the retinal vessels, Galazowski, 1900. Iritis and iridocyclitis. The lesion is not very common. Lapperson saw 1 or 2 cases among 2,000 eye cases, and Kirka 2 in 20,000. In Byers' cases, it was always preceded, 62 cases, accompanied, 9 cases, or followed, 10 cases, by gonorrheal rheumatism. It was unilateral in 48 cases, bilateral in 23 in the first attack, unilateral in 16, bilateral in 3 in relapses. Byers recognizes the following types: iridocyclitis, mild or severe, plastis iridochoroiditis, which may exceptionally proceed to suppuration, exudative, relapsing, and hemorrhagic iritis. The lesions are not clinically distinguishable from similar lesions due to other cause, except by the concurrence of genital and joint gonorrhea or by the complement fixation test. Conjunctivitis. The lesion was bilateral in 42 cases, unilateral twice. In 35%, there were other ocular lesions, usually keratitis. The symptoms are rather mild, the secretion usually mucoid or mucopurulent. There was conjunctival edema in half the cases, swelling of the lids in only 10%. Both ocular and bulbar conjunctivae were usually involved. Gonococci were found in the discharge in many cases. The average duration was 2 weeks, with 5 and 46 days as extremes. Relapses were rare and the prognosis good. Retinitis. The lesion is a neuroretinitis, bilateral 6 times, unilateral 5 times. 6 of Byers' cases recovered, and 3 terminated in atrophy. Other lesions. The other ocular lesions of systemic gonorrhea enumerated above are rare and occur as complications of iritis or conjunctivitis. Diagnosis. The diagnosis of these lesions as gonorrheal depends almost solely on the concurrence of genital gonorrhea and gonorrheal arthritis and on the complement fixation test. The discovery of gonococci in the secretion from the inflamed conjunctiva proves the nature of the lesion, but may leave doubt as to whether gonorrheal conjunctivitis is systemic or local. Systemic conjunctivitis is likely to be mild, bilateral, and accompanied by other ocular lesions. It is always associated with genital gonorrhea and gonorrheal arthritis. Local virulent conjunctivitis, on the other hand, is not associated necessarily with any other lesions of the disease and is usually an intense unilateral inflammation. Treatment: instillation of 20% argyrol solution every 3 hours is of benefit for systemic conjunctivitis. Other local treatment is along general lines, e.g. atropine for iritis, etc. The urethra must be vigorously attacked, as in every type of systemic gonorrhea. The toxins or serum should be administered, though they have not proven very successful.